This is a 10-minute webcast for GPs and other health professionals. It features excerpts from a series of talks given by cancer specialists to GPs in Tower Hamlets in 2011. This talk is about prostate cancer. It's the second part of 3 on this topic. It covers symptoms and issues following diagnosis. The speaker is Jamur Patti, Consultant Urological Surgeon at Barts Health NHS Trust and Homerton University Hospital NHS Foundation Trust.
In terms of symptoms, but just generally speaking, many patients are asymptomatic. They will come to you because their friend or somebody, a brother or cousin, has been diagnosed with prostate cancer, and this has made them very wary, and they've come to you specifically asking for a test, but they're actually very fit and well. And you may then counsel them about the caveats of the PSA test. You can tell them that it's, you can go and have the biopsy. The biopsy will sample areas of your prostate, so if you definitely have picked up prostate cancer in a biopsy, then that's fine, we've diagnosed it. But for those patients we haven't diagnosed any and the biopsies are negative, that doesn't necessarily mean they don't have cancer. It just means that we may not have picked it up. So the asymptomatic patient will come to you and ask for a test perhaps. Then there might be somebody that you've actually checked a PSA on because they had some back pain or they had some lower urinary tract symptoms, maybe even erectile dysfunction, and you thought just for completion we'll do a number of tests, but we'll also do a PSA. Maybe they're in that questionable age group of above 50, maybe approaching 70 even, that you might worry about prostate cancer, and then test it. And then if that then comes back as a high PSA, you would obviously then refer or maybe do a repeat test, but eventually if it's persistently raised, you'd want to refer this patient on to the urology department one-stop clinic. Patients with bladder outflow obstruction, again, probably uremia. Now, uremia in patients where the bladder outflow obstruction is causing a post-obstructive or a post-renal failure, then you might worry about the prostate being the cause of that and do a PSA as a result of them presenting like that. Obviously, patients with low back pain, hip pain, any pain in the axial skeleton would want you to probably do a PSA. Pathological fractures, of course, so it can present in all different ways. But during pathological fractures, orthopedic surgeons are quite aware, and they often take a piece of tissue sample and send it off to the lab to look for metastatic prostate cancer. Thankfully, we don't see the neurological loss that we used to see back in the 50s. And this is, again, due to more awareness, patients come to you, more accessibility to their GPs and to the hospital, and so often we don't very often see patients, but there will still be about 1 or 2 a year that come into Homerton, say for instance, with sudden paresthesia in their limbs, motor loss, paralysis even sometimes, because there's been cord compression, and that's due to a vertebral collapse caused by metastatic disease in the bone. So this luckily not often presents, but that's an acute emergency. They would need emergency transfer to the oncologist for steroid therapy, radiotherapy, neurosurgical intervention if indicated. So most cases we would want to discuss with the neurosurgeons to see if that could be addressed. Once a prostate cancer has been diagnosed, we have different Gleason scores. Gleason score basically is like if anybody's looked on Google Earth and you're looking down at your house, you can see your little house with a nice fence all around it, and that kind of actions or that kind of view is what we see when we look under low power at the prostate's glands. And if the glands all look really well behaved, look really nice, demarcated, then obviously it's more normal, then they have a lower Gleason score. So there might be some abnormalities that suggest that they have cancer, but largely they're keeping within their own sort of structure. If, however, the gland looks like the cells are, or not the cells, but the glands are merging with one another, they're actively encroaching on other glands, neighbouring glands. So on Google Earth, say somebody's fence has been run down and there's things strewn all over the place and you can't really tell whose house is what, that would be a Gleason 9 or 10. So an aggressive type of cancer that's merging with all the other side tissues, and the glandular appearance of the prostate is lost. And somewhere in between you would have your Gleason 7s and 8s. So anything from 7 onwards, we think of it as a more aggressive behavior of prostate cancer. So that's the Gleason score, which we will, you'll notice that when we're writing letters to you telling you about the cancer. Now, sometimes when patients have a very undifferentiated type of cancer, they no longer secrete PSA. So having a very low PSA, always tend to look at the Gleason score and check that it's not an 8, 9 or 10 Gleason score, because that may give you a false sense of security because they're actually not producing PSA. So PSA will be very low. This is because they're not differentiated enough to produce the normal enzymes that the prostate would normally produce. In this case, it's highly likely that they may have metastatic disease, and so an alkaline phosphatase should be checked as well, which is one of the bone markers. So just to make you aware that when you're doing your blood screen, alkaline phosphatase is one of the things you should probably be looking at. So the PSA, aside from giving you a guide as to which patients you might want to biopsy, PSA can also be used to help you with the staging, to tell you what stage of cancer this patient is. So a patient who has been diagnosed with cancer, you look at their presenting PSA, and it will give you a rough idea of what kind of sort of metastatic or non-metastatic cancer they may have. The PSA itself can give us some idea of how aggressive the cancer is and how far gone it is in terms of staging. So a PSA under 10 or 20 is probably suggestive of a localized prostate cancer. If a PSA is 50 or so, then likely that patient has a locally advanced disease. And when it's in hundreds, or even I've had patients in Hackney with PSAs of 10,000 plus, and obviously that's overtly metastatic. The other thing that the PSA does is it helps you with response to treatment. So if the PSA comes whooshing down after a patient's had surgery to remove their prostate and it goes to 0, that probably means that they've had an effective treatment. Similarly after radiotherapy, similarly after hormonal manipulation. But if the PSA comes down only a fraction, say from 10,000, okay, it came down to 1,000, which is a good drop, but it didn't ever come down to 0, or it didn't even come down into 10s, then it's likely that this patient is going to become hormone escaped soon down the line, maybe a few months later. So the PSA is giving us lots of information. So the last bit is the prediction as to how this patient is going to behave in the future. Because often you'll be monitoring the PSA alternating with the hospital, because we might have a 3-month with you and 3-month with our kind of shared care policy. So it's quite important that you understand the workings of the PSA and how it's going to help you. So the other things aside from the blood test that we can do, we can look at MRIs and CT scans. MRIs in particular are our first line when we're looking for localized or locally advanced disease. We're mainly looking at the capsule around the prostate. Has this tumor gone outside the capsule? We can also look at the tumor itself within the prostate, but you may get similar features if the patient has prostatitis, for example, or an infection or something within the prostate. It might give a similar finding. But once you've got a histological diagnosis of prostate cancer, then the MRI is much more effective, because you can correlate that the tumor was on the left side and there's an odd area on the MRI on the left side, it's most likely to be cancer. MRI also looks at the regional nodes, and it can also look at the bones. MRI often picks up bony abnormalities 6 months ahead of bone scans, so it's quite a sensitive predictor of abnormalities within the bone. Places which don't have access to MRI, CT scans also possibility, and CT scans mainly going to look at around the para-aortic regions, looking at the lymph nodes around there. So we often do CT scans for the more advanced cases, PSAs over 50, and the less advanced cases, the probably localized cases, we're likely to do MRIs in, because we're interested in the integrity of the capsule. And of course, bone scans for patients that have clearly bone pain, or where the PSAs are very high and we think that they have metastatic disease. Sometimes in very elderly men with very high PSAs, we may decide not to do a biopsy because of the threat of sepsis in those elderly, frail patients or immunocompromised patients. In those cases, we can get an indirect result sometimes by just doing a bone scan and correlating it with a high level of PSA. So that's something that we could sometimes do. By and large, oncologists do want a tissue diagnosis because we're giving them potentially, they may be eligible for drug trials, they may be eligible for different types of chemotherapeutic agents, especially in the younger age group. So by and large, we would want a tissue diagnosis, but some patients, as I said, frail patients or immunocompromised group, we may decide to avoid the biopsy, or the patient may themselves, through their own choice, decide that they don't really want to go for a biopsy and they would rather just rely indirectly on something like a bone scan and their blood tests.
That concludes this webcast on prostate cancer. This is part of a series of 10 webcasts available at this address. The Small C campaign aims to improve cancer survival through better public awareness and early diagnosis in East London. You can find out more at this address. And you will find more useful information on these websites.